Good day, and thank you for joining us. I'm Marilyn Serafini. I'm Executive Director of the Health Program at the Bipartisan Policy Center. Thank you for joining us for today's program. We are releasing a new report here at BPC. We're excited about the integration of behavioral health and primary care, specifically how to make that work in rural America. 40 million Americans, that's 1 in 7 people, currently live in rural and frontier communities. Increased rates of behavioral health conditions remains high in rural areas. This includes mental health challenges such as anxiety, depression, and suicide, as well as substance use disorder and overdose. These rates are really troubling, but if you add to that the greater difficulties that rural Americans have in accessing care, it's an even bigger problem. Here's what we know. 60% of rural Americans live in mental health professional shortage areas. Workforce challenges are continuing, and the social stigma around receiving behavioral health services is also continuing. BPC has produced more than one report in the last several years that creates a pathway to integrating behavioral health care with primary care. Today, we are going to be talking about our newest report, which we released on Friday, that is Achieving Behavioral Health Care Integration in Rural America. This report builds on our previous work that looked at integrating behavioral health with primary care more generally across the nation. Our latest report takes a look at the unique circumstances and, more importantly, the opportunities for increasing integrated care in rural areas. Rural residents already rely heavily on primary care, and that makes integration particularly well suited to these communities. Integrated behavioral health care allows more patients to access mental health and substance use treatment services in a centralized location and reduces the chances that a patient's behavioral health needs will fall through the cracks. Now, integrated care also improves patient health outcomes and is cost effective. We already have some evidence to this end. It allows for a dual response to both physical and behavioral health conditions. That's why we here at BPC are continuing to focus on the power of integrated care. You can find our new report at bipartisanpolicy.org. Before I go any further, I have to give a special thank you to the Helmsley Charitable Trust. Helmsley has continued to support BPC's health program, and especially they have supported today's report and event. I'd also like to introduce Tom Morris as the Associate Administrator for Rural Health Policy within the Department of Health and Human Services, Health Resources and Services Administration. Tom oversees the work of the Federal Office of Rural Health Policy. The office is not only responsible for advising the Secretary of HHS on rural healthcare issues, but for administering a wide range of research and capacity building grant programs that serve rural communities through state offices of rural health. The office also conducts research and regulatory impact analyses on the unique barriers to equitable healthcare in rural areas, which ultimately allows them to provide technical assistance and support to these areas. I'd like to thank Tom for joining us today, but also to thank him and his staff at the Office of Rural Health Policy for continuing to engage with BPC on the wide range of issues that impact rural Americans. So now I'll turn it over to you, Tom.
Great. Thank you very much, Marilyn. I want to thank the Bipartisan Policy Center and the Helmsley Foundation for their focus on this and the notion of integrating behavioral health and primary care in rural America. This is not a new topic. Integration has been going on for quite a while. And yet, I think the bulk of the focus tends to be on how it looks in urban and suburban areas. And so having BPC take this on and sort of look at it through a rural lens, I think is an added part of the larger policy discussion. And the report makes a lot of really great points. I think the most critical thing that I think it brings to the discussion is the notion that it's going to look different, this notion of integration in rural areas. And we have to take that into account in the policy process. And I also think it's particularly timely because, the last year or two, we've seen a long overdue focus on the behavioral health needs in this country as a whole and in rural communities as well. That was true before the pandemic, and it's certainly true afterwards. And the fact that we're starting to see more policies and program and investments in this area is a positive sign. But the real challenge will be, can we integrate this behavioral health and primary care services? Can we do it successfully in rural communities in a way that really improves the experience of patients? And I think we can. More generally, Marilyn, I think you painted a great picture of the current reality. The fact is we've got a big mismatch between the needs of folks and across this country and the availability of services to meet those needs. Nearly 50% of the individuals who need behavioral health care still aren't getting it. And there's a need not only to train more behavioral health care providers, but also get them to serve in the communities of greatest need. And that's a long-term project to really address these long-standing workforce challenges. I mean, the evidence on this, as Marilyn noted, is clear. Integration works. It's better for patients. It's better for clinicians. And so what we've got to do is figure out what are the policy challenges that are sort of making it harder to do, and how can those be addressed? And I think the report does a nice job of sort of summarizing a number of areas where policymakers could take immediate action to sort of address these things. So let's start with some of the things that are driving differences. Obviously, workforce has long been a challenge in rural communities. It's harder to do the integration in rural communities if there's no behavioral health provider to integrate services with. This is something we see every day in our work at the Federal Office of Rural Health Policy. There are currently 216 counties in this country, according to research by the University of Washington, that have no behavioral health care providers of any kind. So given that, it's really not a surprise at all that, as Marilyn noted, that rural areas are much more likely to be in mental health professional shortage areas than urban areas. And what that means is that you're either traveling greater distance for care or that behavioral health challenge is going untreated. And neither of those is an ideal outcome. And the ongoing burden is that there's a heavier stigma in rural communities. One of the things that makes rural communities so wonderful is the close-knit nature of the way that they're set up. But by the same token, that can also create sort of a consideration about whether people are concerned about seeking mental health services for fear of being stigmatized. So it's easy to talk about the value of integrated care, and I can't imagine that anyone doesn't see the benefit. But the challenge is, of course, making it happen and how to account for the unique realities of what we know in rural communities. And so what the report does very succinctly, I think, is lay out a number of different considerations. In the policy area, for instance, it notes the role of community health centers and rural health clinics as key access points for primary care in this country. The health centers in rural America also offer behavioral health services. Rural health clinics a little less so. But there is a provision in the president's budget this year to create a new program to expand behavioral health services into rural health clinics with startup grants. So that's a good starting point as well. The report has a number of other recommendations that I think really make a lot of sense. For instance, primary care providers get a health professional shortage area bonus if they bill for a Medicare service of 10%. So why isn't that also available to behavioral health providers as well? It might help with recruitment and retention. We all know, thanks to the pandemic, the value of telehealth in providing services. And if you look at the data, it's clear that by far the number one service we see offered in telehealth, both in rural and urban areas, is behavioral health. But the challenge is, how do you sustain that when you don't have broadband access and when there are a number of other operational challenges that need to be met as well? Obviously, building a more robust rural healthcare, behavioral healthcare workforce is going to be needed to really make any headway here. So we've got to think about how to get the right students into those training programs that are more likely to practice and make a career in rural America. The report also, I think, does a nice job in terms of looking at access considerations. And I think when you start talking about network adequacy, that really looks a little bit different in rural America because of time and distance to travel to care. And so we want to make sure people have access to the broadest range of insurance options that are out there, both public and private. But we also want network adequacy standards that make sense for the rural reality. I think the report's discussion of this really goes a long way towards explaining that. And then I think we also have to think about what this means for tribal populations. We know that we have a lot of veterans living in rural communities. And so this whole notion of integration between the VA system and how people can also seek care in the private care system, that's a consideration that I think is particularly true in rural communities. The timing on this is also really great because, as you know, CMS took a number of steps last year in its rulemaking under Medicare to expand access to behavioral health care services. And then Congress turned around and authorized direct reimbursement of 2 new behavioral health care providers under Medicare. So licensed professional counselors and marriage and family therapists a year from now will now be able to bill for services. And it may be that these are clinicians that are a little bit easier to recruit and retain in rural America. And so those steps, along with the number of steps outlined by the report, I think give us a nice roadmap for a way to really start making some headway in terms of integrating behavioral health care services in rural America. And so thanks again for the opportunity to join you today. And I really hope the report gets a wide distribution and take up.
Thanks so much, Tom. Really appreciate you being here. And we always appreciate the work of you and your team to really work on behalf of getting access, to work on behalf of rural Americans to improving their access to healthcare. So thank you for that. We're going to turn now to Julia Harris. Julia is an associate director here at the Bipartisan Policy Center. And Julia has been leading our policy work in all of our behavioral health work. And she's a real asset to the team. So let me turn it over now to Julia, who will introduce and moderate the panel.
Thank you, Marilyn. And thank you, Tom, for that amazing introduction to our report and for your leadership over many years. I'd like to remind viewers that we're going to take audience questions near the end of this panel discussion. And so please be sure to send us your questions using the live chat function on YouTube and via Twitter using hashtag BPC Live. So our report that we just released highlights opportunities to expand, as everyone has said, the integrated care delivery in rural America. We very concretely set out a set of 15 recommendations for Congress and the administration. And I'll just briefly summarize. The first set was around foundational aspects to integrated care, including establishing the core service elements of integrated care with the input of stakeholders, including rural providers, to help better align payer, provider, and patient expectations across care settings. The second group of recommendations support the rural workforce through integrated increased incentives, such as the Teaching Health Center graduate medical education program. The third set relate to payment and care delivery. Given that many rural Americans receive care, as Tom mentioned, at RHCs, so rural health clinics and federally qualified health centers, or even since the pandemic, so many more of us virtually receiving care. And the final set of recommendations take a look at unique populations in rural America, including our nation's veterans and tribal communities who disproportionately reside in rural areas and access care through separate delivery systems often. So joining us today, I'm so excited to discuss behavioral health care in rural America are 3 outstanding individuals. Dr. Matthew Duncan joins us today from Dartmouth Health, where he serves as the clinical director of integrated care within the Department of Psychiatry, as well as an assistant professor of psychiatry. He has authored several articles related to psychiatric care delivery in rural areas and through unique payment models. Welcome. Dr. Octavio Martinez joins us from the University of Texas at Austin's Dell Medical School, where he serves as a professor within the Department of Psychiatry and Behavioral Health Services. Dr. Martinez also serves as the executive director of the Hogg Foundation for Mental Health, which supports mental health service, research, and public education projects in Texas. And Tony Ann Richard joins us from the Healthcare Collaborative of Rural Missouri, a nonprofit rural health network serving uninsured and underinsured residents of Lafayette County. Tony Ann is the executive director, in which role she oversees the organization's commitment to seeing over 25,000 individuals in accessing both primary care and behavioral health care, as well as dental and well child services. So I am very excited for these 3 panelists, and I'm equally as excited that we have a set of folks here who are outside of the Beltway and are going to give us perspective from 3 great states. We've got New Hampshire, Texas, and Missouri. And so just to kick off our discussion today, I really, we focus on integration. And as Tom and Marilyn said, we've done a previous report on integration at a global level, and often rural communities are left out. Mental health and substance use problems are prevalent everywhere. What makes rural America different? Why is it important to talk about integration in rural specifically? Now I'm going to kick that over to Octavio first, and we can then just quickly think about, answer, what do you think that makes rural America different?
Thank you, Julia. I'm glad to be here with my colleagues. Great question. I think rural America is very unique, as those of us that live in rural America understand. I live in Comal County between Austin and San Antonio. It's quickly becoming urbanized, though, so it's not as rural as it used to be. But one of the unique things about rural America is really the rural economy. I think we should take that into consideration, especially because healthcare itself is also part of our economic fabric. And the rural economy is, it's resilient, and yet at the times it's very prone to, significant factors that can impact that. And as individuals and their families are impacted financially, it does impact how they can then access healthcare and the resources they have. For example, is just thinking about our farmers and ranchers and how the weather patterns now really impact them, and it can happen in minutes or within, or days or such. The other thing is that I'd like to add, and then I'll let my colleagues weigh in, because there's a few things I could probably talk about that, but I don't want to take the thunder away from Matthew and Tony Ann. But also, I think the increasing diversity that's happening across our rural area is really significant and important as well. You've already mentioned some of them, especially like our veterans and such, but we are having a significant number of increasing diversity of different, cultures coming together. And I think that changes the dynamics in rural America, and really impacts then the resources that are available to be able to ensure that everyone is receiving the best care and outcome possible when it comes to their mental health and their physical health.
Great. Tony Ann, would you like to add on?
Sure. So I'll echo what Octavio said. And I think really what we're trying to figure out in rural communities is how to make things happen, how to get things started. And so we know that in rural communities, we often have to get creative about how we serve people. And that can happen in a lot of different ways. The modifications that have been put forth by CMS to allow for different types of providers to provide care will be a huge first step, especially with our special populations. You mentioned the veterans, but we also have migrant and seasonal workers that come into our clinics, and homeless populations. And so having an opportunity to have a diverse type of providers will really, I think, catapult us into a creative space where we can start to develop some solutions that are not only good for the patient, they have excellent patient outcomes, but they also are affordable, and most importantly, they are accessible. I don't know, most communities for psychiatry is several months wait time for a psychiatric evaluation. And so integrating that with primary care, there are some things that primary care providers can do to start that process for psychiatric needs, and then do a soft handoff to that psychiatrist. And so building up those providers, diversifying how we provide care is an excellent first step.
Yeah, absolutely. And Matt, I don't know if there's anything you want to say about what makes rural America and New Hampshire unique.
Yeah, thank you, Julia. From a clinical perspective, and these have been touched on by others, one of the biggest factors is geography and distance, and the time and resources that puts the burden on patients. Tony Ann mentioned months to see a psychiatric provider. Here in northern New England and New Hampshire and Vermont, that could be 2 hours of one-way trip for that 60-minute visit. Time away from work, cost of transportation, sometimes reliability of transportation is a huge factor. And And that accessible network oftentimes is very consolidated, in remote regions away from those rural areas, or just simply not accessible. And then another aspect, which I don't know is truly unique to rural, but it feels like it gets magnified, is families with co-occurring psychiatric illnesses among the family members, oftentimes living in the same households, and intergenerational illness as well. And I know that applies to urban populations equally, but certainly is an impact on rural populations. And as Octavio was talking about the financial and economic factors, I think that those familial and intergenerational factors, which are oftentimes very present in the rural population, just add to the intensity of some of the needs of our patients.
Yeah, thank you for that. And as we talk about, the availability of services and the distances folks have to travel, one of the big impacts on the availability has been lately, especially, we're hearing more and more about workforce shortages. And they are more widespread than just rural areas, and they go beyond behavioral health services, but it's definitely a huge factor in trying to get the care that people need all over the United States. So we feel it is an issue that, Congress and the administration should continue to work on, and where there is some room for bipartisan engagement. One of the challenges that we try and work through is that practitioners are much more likely to practice where they train, but most medical schools and residencies, as you know, occur in urban and suburban areas rather than rural areas. And so I know all three of you have some experience in this, but Octavio, can you help shed some light on any trends that you're seeing and where you've seen any particular provider incentives be impactful to maybe bringing more providers into rural?
Absolutely, Julie. I'll mention a few. I think one key statistic that's already been thrown out first by Marilyn and then by you is, that 60% of rural America has mental health provider shortage areas. And by the way, guys, for those of our audience, that number has pretty much stayed about the same since the Eisenhower administration. We're talking about over 60 years. Now, you can look at it negatively, like we made an improvement, but on the other hand, we can see it positively in that we haven't lost either. So rural America has been rather resilient, but that isn't handling the need and the issues. And the pandemic has definitely accelerated and expanded the need for more mental health services and substance use services by our specialists like psychiatrists and stuff, but definitely it's landing on our primary care providers, as we've been talking about and already mentioned. I think one good trend is, though, that the recognition and the fact that we're now discussing rural America and not the cookie cutter approach where the urban model is just being fitted into that. Tom kind of brought that up. And his office and working with him and HRSA and the federal government is recognizing that now and really paying more attention. So that's a wonderful trend. Can't happen fast enough for those of us in rural America, of course, but it is happening. As an example, here in East Texas, we now have a new, residency program, primary care, dedicated to the rural setting. So that's going to make a big difference. And we also have another one. The Hogg Foundation itself is helping with an FQHC to set up a residency program for dealing with rural mental health issues. So I'm seeing that trend. So that's going to help, but it takes time to develop these providers, right? And I think that, as I mentioned, it can't happen quick enough. And another thing that we can happen at the federal level, but even at the state level here in Texas, there's been lots of discussion, and we just finished our legislative session. The ADA, in fact, is to put more money into providing loan repayment program. And I love the loan repayment program because it hasn't been utilized enough, in my opinion, or has enough funding and really targeting and ensuring that rural providers, not just the physicians, though we need them, but also our other providers, nurse practitioners, social workers, psychologists. We need the whole sort of team to be able to take advantage of that. But also another trend is looking at discussions I know we've had here in Texas about looking more upfront, because it's very interesting how expensive now it has become to train our providers. And so maybe growing our own, coming from rural portions of our state, where the community can really identify and help students who want to go into the health professions, but pay up front, sort of like we do with the military, where we pay for and then you give back for 3, 4, 5 years, whatever the case may be. So instead of loan repayment, which is on the tail end, it's also becoming more proactive and paying on the front end. And as was mentioned by Tom, and I think is something also that we've been discussing here, and I'll end with this to let my colleagues weigh in, also is providing that bonus payment and recognizing we do need to actually have and recognize the challenges and difficulty in providers in rural America, and compensating them appropriately for that, because I think that would really help as well, given the fact that Medicare and Medicaid, unfortunately, don't pay our providers, especially our primary care providers, I believe a sufficient rate, which is another policy area we can definitely work on.
Thank you for that. And Tony, and Octavio highlighted many different strategies. Are there any in particular that you see working in Missouri? Any retention challenges that you've grappled with?
Sure. I think the grow your own mentality is really catching on. I had an opportunity just last week to meet with a psychiatrist who has been practicing for about 25 years. Her daughter just recently also became a psychiatrist and is looking to get back into a rural space and following in her mom's footsteps, but also has an interest in expanding capacity within our rural communities. And so I do think that identifying people when they're young, and fortunately or unfortunately, that's happening even in the middle school area, when we're identifying people who want to go to medical school. Do they want to be a psychiatrist? What are their interests? And so finding some space for people to have opportunities, whether that be through an AHEC program, through a medical school that does some outreach, as Octavio mentioned. A lot of times they are in the urban area. And so how do you get them out into the rural communities, and allowing for some of those shadowing opportunities and spaces for kids to get more involved? I also think that mental health is becoming a really comfortable word. 10 years ago, we didn't even say mental health. We didn't talk about it. It was kind of hush hush. And now the pandemic, I definitely think brought that to the forefront of some conversations, because it was so visible within our communities. So we're talking about it. We're having some really hard conversations around things like generational depression, PTSD, even postpartum depression is becoming really common. And you see women reaching out to women to say, hey, I know how you feel. I went through that too. And so I think the more that we can encourage mental health services to become mainstream in our conversations with our friends and our family, you will see some of that come to be important to our young people. And right now we're really relying heavily on them to carry out this mental health work.
Yeah, absolutely. I think the more that all of these conversations can happen and normalize the stigma, the better better off we all are. And so you have both raised some strategies that actually are within our report. We do believe that there should be incentives to a broader group of behavioral health providers to practice in rural areas. So not just physicians, but as you said, different behavioral health providers. One strategy is to leverage bonus payments that go already to physicians that practice currently in rural areas, to broaden those to hit other types of behavioral health providers. And another strategy that we bring forward is, how do you potentially leverage our tax system to create a federal tax credit for rural providers? Several states already do this now, leveraging their state tax system to bring providers into rural areas. And we also want to see if that can be a federal strategy as well. And there are a number of recommendations in the report also around paying for the teaching GME, and so we wholeheartedly agree with a lot of the advice that you all have raised. So appreciate that. I think I want to jump to next, just because we have talked about it with Matt in the as we were developing this report, and would love to have him weigh in here. We've talked a lot about the collaborative care model, and we talk about it in the report, and it's increasingly become adopted as an effective approach to integrating primary care and behavioral health services. Many studies have shown that it improves outcomes, excuse me, increases provider confidence in delivering integrated care services, and can lead to cost savings. And so I know, Matt, that in your practice, you are actively figuring out what are the barriers to uptake of the model, and like all the quick and dirty things that you've had to figure out sort of on the fly to make that model work better. And so if you could give just a high level explanation of what the model, how the model works, and then talk about what are the benefits that you've been seeing in implementing the model.
Yeah, thanks, Julia. For the collaborative care model, I think the first thing for people to recognize is that it is intentionally designed for primary care. It is not a behavioral health delivery model, it's a primary care delivery model. And I think that's really central and important to what we're talking about, which is a cultural and system transformation change. Within that primary care space, then you are adding new team members and you are adding new tools to do the work. So you're putting in behavioral health care managers or clinicians, supporting them with consulting psychiatrists, and everyone is in a team way partnering with that primary care doctor who still retains the primary relationship with the patient and really oversees all of that care. The other parts that are central to the collaborative care is that it is required and incredibly useful that we use structured patient-reported measures, both for identifying people, tracking their outcome, and helping know whether they got better or whether they need more. And so people may be familiar with some of these clinical tools that are common for depression, anxiety, substance use, et cetera. And the other element that's really significant is that the collaborative care model requires that the population of patients are actively tracked on a patient registry, and that patient registry is reviewed weekly with the consulting psychiatrist and the behavioral health care manager, and communicating back to the primary care doctor. So that model structure where you've got something adapted to primary care, clearly evidence-based, you've got new specialized team members, and then you have these tools that structure it. It's very robust. And some of the advantages, probably the biggest advantage in my mind is timeliness. You can start delivering active structured care the day that person contacts their PCP. And if we juxtapose that, with what was mentioned before, where that can be 6, 9 months or more, that is an incredible advantage to not let untreated illness go longer. Because once people present for help, it's already probably gone longer than it should. So timeliness is really key. The other is that just navigating the system, many patients are comfortable with primary care. They know where to go, they know how to access it, and primary care is welcoming. And so you're not having to then cast them into a whole new system of care that has its own wrinkles and rules and complexities. So that reduces a lot of the stress inherent to it. And then having practiced as a psychiatrist in both a collaborative care model as well as a traditional outpatient mental health model, these usages of standardized tools that really tell you how a person is doing, I will tell you, I have more confidence that the patients I'm treating within collaborative care are more likely to get better, because we're actively watching them and we're watching their symptoms improve. So that timeliness, that structure, and that ease of use are some of the major advantages that I've seen.
Awesome. And I know we've also talked about the research that you've done around opioid use disorder treatment within primary care as part of the collaborative care model. And I know that has been a big part of BPC's work, thinking about, we've had years of advocating for the removal of the X waiver Can you tell us more about the benefits of practitioners being able to treat for primary care and behavioral health addiction treatment when issues are co-occurring?
Yeah. So we have developed procedures, tools, and pathways for opiate use disorder and alcohol use disorder that are the same or similar as what a primary care practice would do for depression and anxiety. So I think on the very first level is putting those in the same vein, kind of making them equal to one another, that we in primary care with this support can treat either adequately. We then have really clearly delineated what the roles of the team members are. And I think that when you're dealing with things like opioid use disorder and the complexity of the issues those patients face, it's really important to know what is the PCP's responsibilities, what is a behavioral health clinician's, the consulting psychiatrist, the nursing staff. So that clarity of those role delineations is really important. And then making it so that for our primary care providers, it's doable. And just a really quick anecdote. We had a new provider come into one of our clinics that practiced in an urban area for about 10 years, had a waiver, had never used that to prescribe buprenorphine. And within the first 2 weeks, using the collaborative care tools, they were prescribing to their first patients. And they said, I never knew it was that easy. And it really was because it was part of the program. The roles were well delineated, and the provider could do their piece and feel useful to address the patient's needs. So it can be done effectively.
Yeah, that's incredible. And I'll just open it up to Octavio and Tony Ann if there's anything else you'd like to comment about, specifically the ability, the benefits of bringing in addiction treatment within primary care in your experience.
I'll just add, I think Matthew's done a wonderful job of giving the picture. What it lends itself to, the collaborative care model and true integration, as he's painted it and pointed out the key components, it's a holistic approach to providing care that really makes providers feel they're making a difference. But also we know that patients are then actually having good health outcomes and feel really connected much more to their providers. And as he pointed out, it's a team-based approach. And so the one thing I do want to add is how important it is that we continue to make the changes needed in our educational settings to ensure that our providers of the 21st century that are coming out understand the integrated model, the collaborative care model, because they can, and that they're training in those kind of settings. We've been making some progress. That's a good trend, but I think there's a lot more we need to do to ensure that they understand team-based approaches, because we're talking about bringing different types of providers together to work together. And we all know, those of us here and even probably in the audience, we have our own cultures and philosophy of how we've been trained. And the team-based approach really, I think, is a game changer, and it's a paradigm shift of how we can actually, as Matthew pointed out, really work at the best of our abilities together. For who? For the patient, for the customer, for the individual, because that should be our primary focus. So I think education settings, the more we can continue to ensure they're having the experience, the students and the trainees, as they go through this, will enhance and go through. And talking to students at the undergraduate level and at the graduate medical level, myself, it's also, I think, generational. They're really wanting to make a difference. They want to feel connected, and they are, I think, much more open. If you take a look at how psychiatry has been increasing, not only in interest, but in the number of slots that have been actually filled, it's just exponentially been increasing year after year. And I think it speaks a lot to what Matthew pointed out are the benefits of an approach like this, a holistic approach. So I turn it over to you, Tony Ann.
So just a final comment on that is that these types of programs are what give our newer providers, younger providers, and existing providers tools in their tool belt. And so it allows them a quick resource that they can then address as many patient issues at that visit that they can. And so I think sometimes we forget that in rural communities, we're asking providers to practice at the top of their scope every single day, whether that be a nurse or a physician or a psychiatrist. And so looking at a collaborative approach gives tools, it makes it easy, and it also provides a safety net of comfort for care as those providers are writing treatment plans and coming up with solutions. I think around addiction, we're just really tipping the iceberg in Missouri. The removal of the X waiver was significant, but we have so many more people in our communities that we haven't reached yet. And I agree that by having an open door, no wrong door policy, to be able to receive some of those services in the primary care setting along with behavioral health is really critical.
And I will actually grab an audience question just because it's related to the comments around the importance of team-based care. And we do have an audience member that has asked, can we please address the role of peer support services? I think especially as we're talking about treatment for addiction, we have seen a lot of evidence to say that peers are incredibly powerful in our ability to reach folks that have issues with addiction. And so what are the challenges in expanding peer support services?
I'll start and let my colleagues weigh in. Julia, I think peers are a wonderful component and expansion now to the team-based care approach. Yes, it did start with in the last century from substance use mostly, but it's really expanded now much into behavioral health, which is mental health and substance use, not to mention, of course, even in physical health, working with elders and stuff. There are now really peer specialists at all different types, including like forensic peer specialists, those that are in the outpatient setting, even inpatient setting, ER settings. Very much so, Hogg Foundation has looked into and supported bringing in peer specialists into the collaborative care integrated model. One of the challenges that initially had, I think that peers have been dealing with is acceptance as being part of the team and the comfort level of those that don't understand peers. Often my colleagues like that are physicians is accepting having an individual with lived experience to be actually part of the treatment team, so to speak. And I think that it can be, that's a challenge, but through certification, through training, through actually having a formalized process to bring them on board is one. The second one that we've been working with here is actually not only ensuring that there is a body of knowledge that peer specialists bring to the table, and identifying specifically, as Matthew mentioned, that we all know what our roles are, including the role of a peer, but also is ensuring that they are being reimbursed appropriately and have a living wage. Otherwise, it's very difficult for a clinic, and especially a primary care clinic in a rural setting, to bring on a peer in not just in a voluntary format, but in fact being a paid, subject matter expert in peer services to the table. Those have been some challenges that I think we need to address to ensure that those are being treated and seen as then now as being part of the treatment team.
And I will just add, one of our recommendations as folks were talking about how do we give this information to providers in a way that they can actually train to prescribe buprenorphine to patients with opioid use disorder and have that mastery of addiction medicine. One of the recommendations in the report is really, removing this practice where addiction treatment can be often segregated from standard training, but bringing it into the medical school curriculum directly and having that expertise start to be built from the time folks are in medical school. And so I will, let's move to actually one of the things that Tom mentioned in the introduction, which is just how much care for these communities is provided through rural health clinics and federally qualified health centers. They've served millions of Americans each year. They are particular importance in rural America and are increasingly delivering behavioral health services. So huge spikes especially during COVID that FQHCs saw in their behavioral health service capacity. And I just want to turn to you, Tony Ann. FQHCs and RHCs are providing all this care, but they continue to face challenges to delivering integrated services Historically, there have been a lot of barriers, administrative and regulatory barriers to integration. For example, restrictions on same-day billing, which in some states are still an issue. Can you give the audience a sense of some of the regulatory and administrative barriers faced when trying to integrate care? And actually, same-day billing, just for the audience members who don't know, is where you were not allowed, or in some places still not, to see a provider for your physical healthcare needs and your behavioral healthcare needs on the same day, which creates a lot of barriers for people who are having to take time off and travel and get to care. Go ahead, Tony.
Sure. So yeah, same day billing I think will probably always rise to the top until that becomes a federal fix. I'm going to leave that to Tom and his colleagues to continue to attempt to solve that. The other thing is the telehealth provisions that were put into place during COVID-19, the pandemic, have been phenomenal. I think that we saw our no-show rate go from, I think, about 35 to 40% down to 6 or 7%, specifically around mental health, behavioral health. And so there's a sense of self if you are receiving some services via telehealth. But we can only continue to do that in the FQHC, RHC setting if those provisions remain. There is some federal fixes that are out there. There's been some continuations that have been extremely helpful, but to turnkey that entire program into a fair, reimbursable solution will be extremely important as we think about how we're delivering care. And so I think if those two things can really continue to be addressed, there's a lot of people championing that initiative. I've never heard anybody say that it's a bad idea. I think it just comes down to money. And so then also taking a look at how are we able to reach people? Are we able to reach people in their homes via their smartphone, via audio? Are we able to reach them in community-based settings? What are the opportunities around group work that's going to be allowed in the outpatient clinic setting to really work on prevention? You look at programs like AA and NA, and the reason that Al-Anon, the reason they're so successful is because there's a group of people with a common goal that is sitting around the table. I'll just echo on the peer recovery support coaches. Every state calls them something different. The community health worker model, when it became a thing, I think a lot of rural communities had community health workers before the community health workers were cool, right? So when we switched over and made that an intentional work, what we saw was we started moving the needle, and we started moving that with our diabetic patients, with our hypertensive patients. When we added peer recovery support coaches to that mix, it exploded. There's just something about lived experience that says, hey, I'm going to walk alongside you, and I've been there. I've seen all of the ugly, I've seen all of the good, and we're going to work on that together. I know for our organization, having peer recovery coaches in the clinical setting, in the community-based setting, alongside of their physical and mental health work is extremely helpful, and something that we will continue to advocate for well into the future.
Yeah, I love that we're highlighting so many important tools, and actually an audience member question also has come through. And I believe it is related to something that does come through strongly in our report, which is the importance that we put on the ability to have interprofessional consultations as a tool in the delivery of integrated care. And so they allow for care teams to get the guidance they need from experts without full referrals. And you can continue to remain in the same location, which is a really important from the patient's perspective. And so the consultations allow primary care clinicians to fill those knowledge gaps. And what has been the role of telemedicine in allowing for interprofessional consultations to be used more? And I will pass that over actually to Matt, just if you could kick us off.
Yeah, happy to. We've been working on delivering a couple of different telemedicine-based services that are direct to providers, which are distinct from those that are direct to patients, since we are doing both. For the direct to provider, we have an e-consult service, which is an asynchronous form where they can send in questions and then those are answered typically within 24 hours. And that's a very efficient use because it does not require the provider to stop their workflow to match their schedules with a consultant in real time. So that asynchronous works for many of those activities. The other format that we've used is the ECHO format, which is really kind of a group educational format. And we've really expanded that from, clinical to social determinants of health topics to support for schools. So that's a model that started around hepatitis C management in New Mexico, I believe, but has been really well adapted to support providers through telehealth platforms. Another version that we have are consultations direct to emergency rooms, rural emergency rooms and providers. If they have patients who are in need of psychiatric assessment, it can be direct to patient, or if it's just the emergency room provider who may not be a mental health specialist who needs to evaluate a patient, that telehealth into those rural spaces. So that area has really developed into multi-modalities that is creative. And I think each of those have been successful in their own right.
And Julia, can I add? It's
Absolutely.
great to add on to what Matthew has already shared. It's also looking at the National Network of Child Psychiatry Access Programs, or that concept and that model. Massachusetts did it many, many decades ago. Texas, right before the pandemic hit, we stood up a child access program because we don't have enough child adolescent psychiatrists for urban areas, let alone for our rural areas. So how could we help all our communities across the board, but especially this has been very beneficial, as Matthew's pointed out, to rural America and rural Texas. And what we've done here in Texas is actually we identified all the already existing areas of expertise which are in the urban areas. So with our institutions of higher learning, our medical schools, and health science centers. And in fact, that's a hub, and breaking up the state into regions, and each of the hubs then is able to have a catchment area wherein, to Matthew's point, in real time can provide consultation there. And of course, and for children, it's actually our pediatricians and family practitioners. And so for them to, in less than 30 minutes, be able to ask the question and have it answered so it does not disrupt their clinic, but in fact the flow can continue and be able to, and usually they can handle the majority of the issues. They just often just need to hear from a specialist, am I on the right track? Do you have something? They're really good questions. And to his point, there's also a built-in educational component to that. We've now been talking about, because that has been successfully stood up here in the state of Texas. And like I said, there's a national network out there. But what about, since we know psychiatric issues affect not only our children and our youth and our adults and our elderly, is standing up an adult access kind of network that can also mimic what we've been able to do in child psychiatry. So I just wanted to point that out. It's really maximizing, just like Tony Ann has pointed out and Matthew, our technology. It can really be quite beneficial. It's not the complete answer, but it could make a really big difference and provide and bring expertise to our primary care doctors and to our rural communities so that they can take advantage and have the best health outcomes as well.
Thank you for flagging that. That is an incredible program and model, and we've definitely been supportive of expanding.
Can I add one other thing, Julie? Is because
Sure.
It's the report, and it ties into this, is the fact that, and we've been pushing here in Texas, and I know nationally it's on the agenda as well, which is the infrastructure needed to have these things happen. We really need to see broadband as a utility, in my opinion. It is just as and uniquely needed as water and electricity is for any area of the country. If we do that with broadband, because it's not just for health, it's also economically needed, as well as from an infrastructural standpoint, as well as educationally. So those are three big systems that would benefit from broadband in every area of the country.
Absolutely. So I want to actually go to one of our special populations that we looked at in the report. And one of our recommendations was for the Department of Veterans Affairs to provide additional support to service members that transition into veteran life as a result of a mental health or substance use related condition. It's kind of amazing. You think about the VA estimates that nearly 1 in 4 veterans, or 4.7 million people, settle in rural communities after they complete military service, and yet only 60% of them are officially enrolled in the VA system. So there are many veterans who serve their country and are missing opportunities to access benefits. So I just want to get your take, and Torian, maybe you can kick us off. What are some of the unique unique problems that veterans are facing, and how do we better ensure that they're getting behavioral health services that they need?
Sure. So I think we would all agree around the table that as it relates to veterans, children, and our entire country, that as leaders in healthcare, we have a big responsibility to continue to address and find solutions for these issues, and that we need to get better. What we find in Missouri is that veterans, a lot of times, in order to get services outside of the VA, which is typically in an urban area, the wait times are significant. When they are then able to get an appointment, seems like transportation comes up, or there's an environmental issue that just makes that person feel like they can't make it to that appointment that day. And so then those issues continue to be set back. We're not addressing them, and they continue to grow. The Veterans Choice Program, which allows veterans to be seen in a community-based setting, is a great start. I mentioned at the very beginning of this session that I think you've opened up this iceberg, and we have sort of a roadmap to start chipping away at some of these issues. But it still has to come down to the choice of the patient. And if they're choosing to seek community-based care, and those services are readily available, and they can be seen sooner than they could be seen in an urban setting, with additional barriers specifically around transportation and access, we need to make that happen. And so I know the question is really based around regulatory and policy. I think there's a whole lot around regulatory and policy specific to veterans that we could dive into. But at the end of the day, we need to give the veterans the choice of where to seek that care and how to seek that care. I think going back to Dr. Duncan's program, the collaborative care, that's something that could be easily duplicated within the VA system. And so figuring out ways that the local providers can work with the VA system more intentionally about sharing the information that is necessary, making sure that things are simple and things are easy for the patient. At the end of the day, it comes down to where do they want to seek their care, because they're going to be more likely to be compliant and also continue to come back and further those treatment plans if they're making that choice on their own.
All right,
Julie, can I add one thing there?
Yeah,
Well covered. It's that transition, though, also from active duty to civilian life. And as you pointed out in the report, folks should read, is about the VA Solid Start program. I think it needs to be robustly funded. I think because those transition points are so important, and because of the unique culture of the military, but also the interface really of also rural culture. And it really speaks to, and it really is attractive to many of us that have served in the military. And it's also an area where I think and the VA's done a great job of this. Their peer program could really be part of the VA Solid Start program and to really enhance that, to help that transition so then they can access everything that Tony Ann just mentioned.
Well, with that, I want to thank all three of our incredible panelists today for joining me and elevating these issues on behalf of BPC and just all the work that you do in your states. So again, if you're interested in learning more about our work and our latest report, Achieving Behavioral Healthcare Integration in Rural America, it can be found at our website, bipartisanpolicy.org. Thank you all.